I'm Daniel Levine, and this is the Bio Report. Esophageal cancer is a growing healthcare concern, with a steady increase in the number of cases in the last 4 decades, a development that runs counter to what's been seen in other major types of cancer. Some 22,000 people are diagnosed each year in the United States with the disease, and it's responsible for 16,000 deaths each year. Now, though, Lishan Aklog, chairman and CEO of Lucid Diagnostics, says esophageal cancer is preventable through early detection in the pre-cancer stage. We spoke to Aklog about Lucid's test to detect esophageal cancer, how it works, and its potential to change outcomes for people with the condition by catching it before it turns into a deadly cancer. Lishan, thanks for joining us.
Thanks. It's great to be here. Thanks for having me.
We're going to talk about esophageal cancer, Lucid Diagnostics, and its EsoGuard test to detect early signs of the disease. Before we talk about all of that, though, I wanted to begin with your own story and how you came to found PAVmed, the parent of Lucid. You fled your home in Ethiopia at the age of 13 with your teenage sister. This was during a time of violent government suppression of dissent known as Red Terror in the late 1970s. Where did you go and how did you make your way to Harvard?
Yeah, that was a pretty good summary there, Danny. So yes, things were very difficult. There was a lot of political violence. Luckily, my father, who was the first cardiologist in Ethiopia, had contacts and was able to arrange a family in Naperville, Illinois, in sort of suburban Chicago, for us to live with. 2 different families, one for me, one for my sister. They were affiliated with a church, and it was the minister at that church was the one who coordinated and organized us, that allowed us to be able to come. So, I was 13, she was 15. We got put on a plane, changed planes in Paris, landed at O'Hare, and found ourselves here in America, going to high school and living the American dream.
Your father was not only a prominent physician, but your mother was Harvard educated with a graduate degree and also an academic. Did they stay in the country or did they join you?
They stayed. Yeah, my mom was, just to give her a few props, my mom was the youngest in a family of 12 and the only girl that was actually allowed to get an education. So by the time it got to her, so she was, one of the first of many at various levels. She came to Harvard to get her master's in education in the mid to late 1950s and went back to become the first professor. They both stayed there. They weren't allowed to leave. So we were allowed to leave on a student visa. They weren't allowed to leave. My mom did eventually immigrate here about 15 years ago. And my father, just before he died, was planning on it, but unfortunately passed away about 20 years ago before he had a chance.
You became a heart surgeon. You were actually the youngest to join the faculty of Harvard. How did you come to be involved in the diagnostics industry?
So that's an interesting question, right? You spent a lot of time training in heart disease, and as a heart surgeon, I was a full decade of training before I was actually able to join the faculty. And when we launched the predecessor, the parent to Lucid, PAVmed was really designed to be a medical device company, that sort of, typical medical device that surgeons or interventionalists would use, and I used in my practice as a surgeon. And that was the focus of building a portfolio of technologies within the medical device space. We didn't really, when we launched PAVmed in 2014, we're not expecting to expand our horizons beyond medical device. We thought we were actually being pretty contrarian to the extent to which we were diversified within medical devices. We weren't just focused on cardiology or cardiac disease. We were looking at technologies across the board. The way we found ourselves unexpectedly in the diagnostics industry is that in 2017, Dr. Dan Simon, who was a colleague of mine at Harvard in the cardiology department, who was the president of University Hospitals Cleveland, and knew that we had launched PAVmed and we were interested in partnering with academic medical centers and physician innovators, he reached out to me and said that he had 3 faculty members that had developed this, once in a generation technology to diagnose esophageal precancer and prevent esophageal cancer deaths, and would be interested. And initially, I said, it's not really in our wheelhouse. We're not. We're more sort of on the interventional medical device side. We knew about this disease because we were trained in thoracic surgery as well, so we knew how horrible esophageal cancer was. But we initially passed. And then a few months later, they published a seminal paper in Science Translational Medicine. And to his credit, he called me again and said, hey, you might want to take a look at the study. And once we did, and really did a deep dive, we realized that we had to, this was too important an opportunity, both clinically and commercially, to pass up. And so that was really the origin story. We went to Cleveland and licensed the technology from Case Western Reserve University and University Hospitals. And we launched Lucid as a subsidiary of PAVmed to take this technology and bring it to patients.
Well, how significant a medical problem does esophageal cancer represent today?
It's a really significant issue. So if we talk about what is the incidence of esophageal cancer, if you look at all cancers, or the top 15 or 20 cancers, all of them have remained stable, flat in their incidence, or gone down over the last 40 years or so, last 4 decades or so. Esophageal cancer, in real stark contrast, has gone up 500% in its incidence over that period of time. So it's rapidly developed to be a very important cancer just by the numbers. About 22,000 patients get diagnosed a year and 16,000 die a year. The other reason it's important, it's an under-addressed cancer. So the 3 most deadly cancers, pancreatic, liver, and esophageal being the second most deadly, all have a very high mortality rate and all share something else in common, which is that we've historically done nothing to try to detect them and to try to prevent those deaths. And despite the fact that if you take those 3 combined, more people die of those 3 cancers than die of colon and breast cancer combined. So we've had an opportunity for a while, and now we have the reality of making esophageal cancer preventable. Every one of those 16,000 deaths is now preventable because we know how to identify them, and we have the technology to identify them in the precancer stage and actually do something that's not common in this space, which is to do true cancer prevention, not just early detection of cancer.
Is it understood at all as to what accounts for the growth in that disease?
It's assumed, although there's no hard proof of it, that if you look at the trajectory of the obesity epidemic, it pretty much aligns with the curves, pretty much aligned with that. So the assumption is that there are some alternative theories that are interesting, such as the introduction of acid-reducing drugs and so forth. But the most likely theory is that it mimics the progression of obesity. Obesity is a risk factor for the development of heartburn, so-called GERD, reflux disease, and that is the number one trigger. Gastroesophageal reflux disease, or GERD, is the number one, is the primary mechanism by which people develop this type of cancer.
It's interesting because it seems counterintuitive that the drugs for acid reflux might be culpable. Is there substantiation of that? It would seem to me it might be used as a preventative strategy.
Yeah, and it's not a it doesn't. So let's dive into that because it's really interesting. Part of the reason why that seems counterintuitive is that we attribute the reflux to just acid, and it's not just acid. There's gastric content, stuff in your stomach, beyond just acid. There are bile, and there's other gastric juices, let's just say, not to be crude about it, but things in the fluid in the stomach that doesn't belong in the esophagus. It's not just the acid, right? And so the mechanism by which the reflux of that fluid into the esophagus where it doesn't belong leads to these changes in the cells of the lining of the lower esophagus, which can progress from an early precancer, late precancer, and cancer, is more complicated than just the exposure to acid. And the reason why theoretically it might exacerbate it, and there's some evidence of this, is that that when you is that the acid, the treatments, what are currently now called proton pump inhibitors like Nexium and Prilosec, and then prior to that were called H2 blockers like ranitidine and cimetidine. Those medications have become highly effective at symptomatic relief. So patients don't feel the symptoms of heartburn, but it doesn't correct the reflux of the fluid in the stomach going to the lower esophagus. And that's why there's some sense that so just to answer one part of your question directly, taking anti-acid medications like modern day PPIs does not, at least most gastroenterologists would say, doesn't prevent the progression of disease from these esophageal precancer to cancer. It may actually exacerbate it theoretically by masking symptoms and making it so that people don't really pursue further evaluation of their reflux and ultimately get an endoscopy at the earlier stages.
How does esophageal cancer manifest itself and progress?
So sadly, the 22,000 that are diagnosed with esophageal cancer every year, most of those patients are diagnosed late. They're diagnosed in stage 3 or stage 4. And it's really tragic. We have a lot of leading gastroenterologists who work with us or on advisory boards, and it feels like once a month we'll get an email saying, "Hey, here's a reminder of why we do what we do." In the case of this cancer prevention technology, and they'll describe almost to a T a very prototypical story of a 50-year-old man with a family of 4 who had heartburn for 20 years, and nothing was really done about it. And came in with fill in the blank, either chest pain or difficulty swallowing or weight loss or anemia. And when we did the endoscopy, there was a big, tumor growing out the esophagus, which made it a stage 3 and 4 cancer and was effectively a death sentence with about an 80% mortality. So that's sadly how the most common presentation. Even on occasion, if by luck you pick up a stage 1 or 2 cancer, but even just a stage 1 cancer, unlike other cancers such as colon and breast and others where a stage 1 diagnosis is a victory, early detection is a victory because you can actually treat those patients with a high cure rate, 90% or so plus cure rate. For esophageal cancer, a stage 1 diagnosis still carries a nearly 50% mortality. So early detection alone is not going to have the kind of impact that you need to try to eliminate these deaths. It means you have to detect this in the precancer phase.
Is that because of the lack of treatment options today?
Partly, although there have been improvements in treatment with like in other areas with increasing approvals for certain immunotherapy drugs, but none of them have proved to be have that kind of dramatic impact that we're seeing with some of these immunotherapy treatments, for example, in advanced lung cancer and in other advanced cancers. We haven't seen that in esophageal cancer. So the mortality rates, despite the incredible progress that's been made, especially with immunotherapy broadly within cancer, hasn't had that impact on esophageal cancer. So if we're going to prevent these deaths, it's not, look, we're rooting for better treatment for those who make the diagnosis, but to have an impact on those 16,000 deaths and really have an impact on sort of the cancer moonshot goals of what we're trying to accomplish, and this would have a big impact, is we have to detect the precancer and prevent the cancer altogether.
How has the condition generally been diagnosed, and what would lead a person to seek medical evaluation for it?
Sadly, again, it's not. So esophageal cancer is generally not detected until it's too late. And that's what's the problem here. It's a silent killer. People have heartburn. Their heartburn symptoms may even go away or decrease when the these precancerous changes are made, right? Because the precancerous changes in the esophagus are, in a sense, trying to accommodate or to react to the presence of acid and stomach fluids there. And so there really is very little that we can, from the point of view of the patient's symptoms, that can be a red flag to detect the precancer. That's why we have to screen patients who are established as being at risk for precancer using this technology. That's why we have to proceed with that. And that's true with other cancers as well. If you think about mammography or pap testing, that's what screening is about. It's identifying a high-risk population and testing them, screening for this particular condition, and trying to identify it as early as possible so that you can intervene if needed.
Lucid has developed EsoGuard. How early can this be used to detect esophageal cancer?
So great question. So just to kind of set the stage and be clear, what we're in the business of, EsoGuard is designed to detect esophageal precancer. That's our goal, to detect it in the precancer phase. So if it's early precancer, it can be monitored. If it's a late precancer, it can be treated, and those cells can be destroyed before they develop into cancer. So we're trying to prevent esophageal cancer, not detect it. Now, that said, EsoGuard is able to detect, also will detect an esophageal cancer if it's present, but the primary purpose is to detect the precancer. And in terms of how early, that's what's really unprecedented with this technology as it compares to other molecular tests that seek to do cancer, to do early detection, is that we're able to detect the earliest stage of esophageal precancer, so-called non-dysplastic Barrett's esophagus. It's the earliest stage where the abnormalities to the cells are incredibly subtle. They're so-called epigenetic changes. They're very subtle changes to the DNA. They're not mutations or other more aggressive abnormalities. And that's what's remarkable. EsoGuard can detect that with almost a 90% sensitivity for the earliest stage precancer, and then everything along the spectrum from that all the way to cancer.
Well, if you do detect precancer, is there a course of therapy that would be advised?
Yeah, this is all very, very well established. It was established before the development of these technologies. That's what's so great about it. The paradigm was already set. So patients with early precancer, those patients don't need to be treated. They need to be monitored. Similar to, like, for example, if you have a colonoscopy and they find a benign polyp, just a regular polyp, they remove it, but they also the main reason for getting that is so you can monitor and make sure that the polyps don't develop into more advanced conditions. So the early precancer is monitored, typically every 3 years, according to the guidelines, with an endoscopy every 3 years. And then late precancers, which the official term for that is dysplastic conditions, where you start seeing more abnormalities in the DNA, but not quite to the level of the cancer, but on its way. That can be treated. That actually is treated. That can be treated with what's called esophageal eradication or esophageal ablation treatment, where using an endoscope, using endoscopy, you can go in and essentially destroy the abnormal cells using radiofrequency ablation. And by destroying the abnormal precancerous cells, you can reliably prevent progression to cancer. So that's the paradigm, that's the algorithm on how to deal with the precancers early and late. And that's why it's so important that we detect this in the precancer stage, and we do so with high accuracy. That's why this is so groundbreaking.
This is a test that's performed in a doctor's office without any anesthesia. Can you describe the EsoGuard device and how it works?
So yeah, happy to. So the device is actually called EsoCheck. So EsoGuard is the actual test itself. It's the molecular test that I talked about briefly. EsoCheck is the cell collection tool. And as you said, it can be performed in an office. It doesn't even have to be a doctor's office. We actually had our nurse here in our offices, and the last time I got tested, it was done in 30 seconds in an office right next door to mine. So EsoCheck is a very clever tool that was developed by the faculty at Case Western, which consists of a capsule that's about the size of a vitamin pill, and attached to the capsule is a soft balloon, which has these little ridges on it that can sample and swab the surface of the esophagus. That capsule is attached also to a silicone catheter, a little sort of piece of spaghetti. And first, the patient just swallows the capsule with the balloon inside the capsule. And once the capsule is in the stomach, the balloon is inflated and pulled back, and the operator will feel a little bit of a tug at the juncture between the stomach and the esophagus. We call that so-called anatomic indexing. That tells the operator, okay, I'm exactly at the point where I need to sample the cells. That's where the abnormality is occurring. I am where I need to be. And at that point, with the balloon inflated, they pull back a couple of inches, 5 centimeters, which is the entire area where this abnormality occurs, and it gently swabs the surface of the esophagus and collects cells on the surface of the balloon. The key feature from that point on is we call collect and protect, which is that when the balloon is deflated and vacuum's applied, the balloon gets pulled into the capsule along with the cells on the outside. So now the cells that were sampled from this area where the abnormalities occur is now protected as the device is being removed from contamination or from dilution by cells in the rest of the esophagus or mouth. That's really key, because what we've accomplished is the ability to do a very targeted and protected sample of the cells exactly where the abnormality occurs, which enhances the signal these subtle molecular signals that we're looking for. So that balloon then gets sent in a preservative solution to a central laboratory that we run in California, and that laboratory performs the molecular test EsoGuard on those cells after extracting the DNA and returns a result of positive or negative based on how much, based on the epigenetic changes that occur on a couple of genes that have been shown to be associated with these conditions.
Would this typically be administered by a gastroenterologist, an oncologist, or someone else?
Yeah, so no, it can be administered by them, and it is administered in some settings by gastroenterologists, but this can be administered by any trained personnel. We've chosen to use nurses and nurse practitioners because we like the fact that they have skills in terms of interfacing with patients. But it's a very straightforward procedure to train an operator, whether it be a nurse or some other clinical personnel, not a physician, to do this. And with training, it can be done with 98-99% technical success rates. Patients are able to swallow it, even those who have a gag and who sort of look at that and say, I can't swallow that. We have really high patient satisfaction. We have data now on over 8,000 patients that will be published soon demonstrating that. There are some practices where the physicians themselves like to do it and not have their personnel, their nurses and others do it, and that's fine. But that's the exception. And the vast majority of these are done by nurses or someone at that equivalent level, whether it be within the physician's office or our own personnel who we offer as device administrators to do this if the physician chooses to have us do the cell collection part of it.
What's known about the accuracy of the test? Are there problems with false positives?
So we have now really comprehensive data in the form of 4 clinical validation studies that 3 of which are published in prestigious journals, 1 which is pending publication, but has been publicly released. And they all tell a very consistent story that the performance of EsoGuard when used with the cell collection tool is really unprecedented for a molecular diagnostic test trying to detect a precancer. We've never seen sensitivities and accuracy levels at detecting this in any other test. I'll give you just a quick example. Cologuard, for example, is a wildly successful test, stool DNA testing for colorectal cancer. It does a great job at detecting cancer. It detects precancer, late precancer, at about a 45% sensitivity, and it's valuable at that level. EsoGuard's sensitivity for precancer is just around 90%, 85 to 90%. And the sensitivity for cancer is approaching 100%. So It's very accurate at detecting these conditions all along the spectrum. Even the earliest precancers, we don't lose any of the performance. It still is able to detect that at that sort of 85 to 90% sensitivity rate. So what does that mean? That focuses on the false negative rate. So there's a metric called the negative predictive value, which is if you have a negative test, how confident are you that you don't have this condition? And those numbers are 99% for precancer and essentially 100% for cancer. So you can feel very confident if your test is negative that you don't have conditions along the spectrum and that no further intervention is required. For the false positives, so tests that are designed to be screening tests like this are designed to not miss abnormalities, but they do accept some level of false positives in order to make sure that you're not missing anything, right? So the goal is to make sure that you're not missing anything. Those that are positive will get an endoscopy to confirm it, and some portion of those patients will have a positive test, and some will end up being ruled out on endoscopy. So this should be viewed as sort of a triage test, right? We're trying to take patients out of the invasive test, the endoscopy, and use this non-invasive quick test to triage and basically say, okay, 80% of you have 100 patients, 80 of you don't need anything further. You don't need an endoscopy. We'll do an endoscopy on 20 of you, and somewhere between 8 and 10 of those 20, let's say 25% will have an actual positive result that needs further follow-up.
I don't imagine a physician will use this as part of a routine checkup anytime soon, but who is this test indicated for? What would be a person who is at elevated risk of esophageal cancer?
Yeah, what's amazing about this technology is that, there's some other amazing molecular technologies that are out there that do incredible things biologically, in terms of the science of it, but it's not clear clinically who should be tested. That is not the case here. So this should be and is recommended to be a routine test in a specific population. Not in everybody, but in a specific population of patients who are known to be at risk and if they have certain risk factors. So the guidelines state that patients who have heartburn, a history of heartburn, and 3 out of 6 risk factors, I'll enumerate those: over 50, white, male, obese, smoker, or a family history of these conditions. If you have 3 out of those 6 risk factors and heartburn, then you should be tested routinely. Everybody with those conditions should be tested. There's another set of guidelines that are a bit more liberal than that. That's the most conservative one that says those patients should be tested. So anybody who fulfills those criteria by existing professional society guidelines should be tested, because if you take that population, heartburn plus 3 out of those 6 risk factors, you have about a 10% chance of having precancer, and that's what we're looking to identify.
What has the discussion with payers been like around the test, and do they generally reimburse for it today?
Yeah, so we've had really good discussions with payers. Payers, as I'm sure you know, are split between private payers and public, and the public means Medicare at the end of the day, CMS. So on the CMS side, we've been engaged with the group that determines coverage for tests like this, a group called MolDX, now for about 4 years. Back at the beginning of that process, fairly soon thereafter, we had pricing established by Medicare pricing, which is we were very grateful for and happy with the amount that was approved for that. And we've been working on collecting the data to secure coverage under Medicare, and we're in the last stages of that. So as I mentioned, we've built up this clinical evidence that includes the 4 studies that I mentioned. We've also collected another type of data that payers look for, which is called clinical utility data. And so now we have a full comprehensive evidence base. We've re-engaged with the MolDX group over the summer, and we're about to submit, looking for final approval of coverage of this test within Medicare. We expect to have that submission very, very shortly, and hope to hear back from them pretty soon thereafter. On the private side, it's not one entity, it's multiple. And so we've worked to build up a sufficient amount of test volume. We did about 10,000 tests over the last 12 months to be able to engage with private payers. That's how this business works. They won't really listen to you unless there are patients who are getting the test and the test is being submitted for payment under that insurance policy. So we've submitted to, I think, 400 different insurers across the country. We've had good conversations on medical policy and providing medical policy coverage. We have some portion of these that are being paid out of network, which is great. But we still have our the last mile of this journey is getting broader medical coverage, medical policy coverage. We now have the data to do so, and that's all fairly recent over the last 6 months. We've been collecting these publications, and we're in a good position to be able to start securing broad insurance coverage.
Getting physicians to adopt a new test can sometimes be challenging. What have the issues you faced been around physician adoption, and what have you done to address those?
Yeah, so that's, having been involved in medical technology, both as a physician, as the customer, and with other products, this has actually been one of the easier physician adoption exercises we've had to go through. It's really not, it's a pretty straightforward engagement. So let's just say we're talking to a primary care physician. We start with educating them on the relationship between GERD, chronic heartburn, and cancer. They may or may not have remembered that from med school or from their prior knowledge. And then we educate them on the existence of guidelines that recommend very clearly what the target population is and make it clear to them. And they acknowledge that they have patients within their practice that are recommended for testing under guidelines. And then we educate them on the availability of this non-invasive office-based test that's an alternative to endoscopy. That's really it. And it's not that hard hurdle. We have plenty of data that we don't get asked about, about having more data. It's a pretty straightforward conversation. And then it really ends up becoming one of logistics at that point. Okay, great. I definitely have some patients. We can mine the EMR in my office, the EHR, and try to figure out which patients fulfill this criteria, and we can set them up for testing. Then simply it becomes a question of who does the testing. And we've provided a menu to maximize patient access, where if the physician office wants to do the test themselves or have somebody within that, which that would be typically the case for, let's say, a gastroenterology department or another specialist, that's fine, or a health system, for example. But if it's a busy, smaller private, primary care physician, they don't necessarily have the personnel. And then we offer them two choices. If they're in a geography where we have a Lucid test center, where we have our own physical location, they can send the patient there for us to test them there. But increasingly, we're testing patients in their office. So we designate a day, a testing day, an EsoGuard day, every couple of weeks, once a month, however it takes, and we will send one of our trained nurses to do this, and they can do up to 30 a day. And so they'll aggregate patients to be tested. Another way we've been able to get highly efficient access for patients is we've done a bunch of health fair type events, primarily focused on firefighters and fire departments, where the incidence of esophageal cancer is substantially higher than the general population, and the focus on cancer prevention is very acute. And so we've done now approaching 5,000 tests on firefighters, and we typically, in that scenario, we will arrange a testing day as sort of a health fair and have patients who are candidates for this based on a telemedicine screen will come in for their cell collection literally at the fire department, and we can do, we've done hundreds of patients over a weekend in that environment as well. So we've structured a system where we have really good maximizing patient access by providing a variety of options as to how the cell collection can be performed.
What do you think the potential here is to change the landscape for esophageal cancer with this test and really change outcomes for patients?
We have our goal is absolutely audacious. It's 16,000 patients die a year. 16,000 patients will die this year in 2024, hopefully less in 2025. And we think every single one of those is tragic. Every single one of them is preventable. And our goal is to eliminate, for people to no longer die of esophageal cancer. And for us to do that with this technology, we have to get out there and get patients access to this test. We need insurers to pay for it. We're making great progress on that, both on Medicare and on the private side. And if we can test right now, very few people are being tested with endoscopy. If we can start getting to 5, 10, 15, 20% of the population, of the target population, that will be thousands of lives saved. And there's no stopping us at this point to get to our goals.
Are there plans for developing additional tests behind this?
Yeah, we have a great laboratory. These next generation sequencing is sort of the epitome of molecular diagnostic testing. So we have a great lab. We have capacity in our lab in Irvine, California. It's a CLIA CAP certified lab with all the latest next generation sequencing technology and other molecular technologies. And so, sure, we look at other tests that can be synergistic, both from the laboratory point of view as well as from the commercial side. And we've been open, and we've explored opportunities to bring in additional tests to take advantage of that infrastructure.
Lishan Aklog, Chairman and CEO of Lucid Diagnostics. Lishan, thanks so much for your time today.
Thanks, Danny. Really appreciate it. Really enjoyed it.
Thanks for listening. The Bio Report is a production of the Levine Media Group. To automatically download this podcast each week, subscribe to our RSS feed or through iTunes or other podcast manager. To join our mailing list, go to levinemediagroup.com. We'd love to hear from you. If you want to drop us a line or are interested in sponsoring this podcast, send an email to danny@levinemediagroup.com. Special thanks to Jonah Levine, who composed our theme music, and the Jonah Levine Collective, which performs it.